Hello and welcome, everyone. Thank you so much for coming. We're going to give it 1 minute for folks to have time to join in, and then we will get started.
Aurora, good morning. This is Carmen. I don't have the interpreter's box.
Thank you, Carmen. I'll get you right set up.
Okay.
Thank you. And for my teammate Carla, we're seeing it in presenter's view so folks can see my comments, if you wouldn't mind resharing a different way.
Sorry.
Yeah, no problem. Thank you. Thank you for bearing with us, folks. Thank you for coming. Please get settled. We're going to get started in just 1 minute.
Is it still showing it?
Yes.
Okay.
If you click that button that says display settings, it'll give you some options and then you can change to the other screen.
Okay, let me see. Let's try one more time.
Thank you,
It
folks.
does actually mean I have multiple screens.
How about that?
Perfect. Thank you, Carla.
Awesome.
Saving the day. And thank you, Dr.
Mhm.
Phillips, for your help
Thank
with
you.
that. But thank you. Good afternoon and welcome, everyone. Thank you so much for attending NACHW's first annual World's Day webinar. My name is Aurora Grant Wingate, and I am the Member and Partner Engagement Associate for the National Association of Community Health Workers, or NACHW. We want to thank you all for coming and thank our panel of experts for being here today. We are excited to celebrate and commemorate the critical role that community health workers have played in the prevention, treatment, and education around HIV and AIDS in the US and around the world. World AIDS Day takes place yesterday on December 1st each year. It's an opportunity for people worldwide to unite in the fight against HIV, to show support for people living with HIV, and to commemorate those who have died from AIDS-related illness. Founded in 1988, World AIDS Day was the first ever global health day. To start us off today, I want to read out some information from worldaidsday.org. Today, over 100,000 people live with HIV in the UK, and they have done research that finds that 63% of the public do not remember seeing or hearing about HIV in the past 6 months. And a third of them say they have sympathy for people living with HIV, regardless of how they acquire it. The survey also found that 1 in 5 people think that they can acquire HIV through kissing, and only 16% know if someone is on effective treatment, they can pass HIV and can expect to live a long and healthy life. World AIDS Day is the perfect time for us to raise much needed awareness about HIV. We today have a once-in-a-lifetime opportunity to end the HIV epidemic for good, but we must also continue fighting the stigma around experienced by people living with HIV. Your support of everyone on the call can help us realize our vision of a future where HIV is no barrier to health or equality. Thank you, and next slide, please. Thank you. We are so excited to announce our panel of speakers today, and we have some additional speakers joining us. We are excited to announce that Alice Ferguson from HRA Wellness Resource Center will be our first presenter, followed by Michelle Cespedes, who is the HIVMA Board Chair. And then I will hand it over to Dr. Tyler Evans, also who is the CEO and co-founder of Wellness and Equity Alliance. And we will finish off our webinar today with Dr. Harold Phillips from the White House Office of National HIV Policy. Next slide, please. Before I hand it over to our first speaker for today, I want to set the stage for anyone who might be new to NACHW. NACHW was founded in the spring of 2019 after several years of planning and organizing by CHWs and allies across the US. We have a vision to see community health workers united nationally to support communities in achieving health, equity, and social justice. As a national organization, we want to be a place of community and a centralized location to celebrate and educate on the importance of the CHW role. Which is why we wanted to take time on special occasions like World AIDS Day to remember the path and see what's coming in the future for community health work and equality in public health. And thank you so much again for everyone being here today. I now want to hand it over and introduce again Alice Ferguson from who is a peer navigator at HRA Wellness Resource Center and recently wrote a fantastic blog from us, which we will drop in the chat. I'll now hand it over to Alice to take it away. Thank you.
Thank you, Aurora, for this opportunity to share some reflections I have about yesterday and its significance. Every World AIDS Day, I spend moments reminiscing about the time when I received my diagnosis and the following years that HIV and AIDS attempted to consume my life, while at the same time, gratitude overwhelmed as I give thanks to God for living now 33 years since my diagnosis. HIV does not weigh or wear on me like it once did, but I believe I am in this universe as a testament, not an accident. Every soul I met while living the 5 years in an AIDS hospice back in 1995 transformed me in numerous ways. I was blessed to be a resident while many of my peers transitioned to their place of peace. That was a monumental time in my journey and is forever fixed in my mind. To all of us who hold dear the memories of a person who is past or is currently living with HIV and AIDS, I honor and thank you for helping to make my walk valuable and make sense. Within every experience, there lies lessons. The key to outlasting a negative lesson is the fight and the endurance we build as we go through it. I've made it my mission to share that perspective and to never give up or give in as I walk as an overcomer. Hope is necessary. It's a necessary approach to life. Yet many times, hope can be hard to find or maintain, especially when first diagnosed with any kind of health tragedy. But it's in that moment when hope is critical. For in that moment, one's mind begins to formulate what you think lies ahead, not what will actually. The fear and trepidation of stigma and rejection blooms for many. The fight for your mind, notwithstanding the fight for your body, begins immediately. The length and level of devastation one goes through depends on what you know, who you know, and the follow-up care you receive. As a woman of a certain age, I learned the key to living above HIV and AIDS was as a result of my always receiving quality health care. This factor is the reason I'm able to give this commentary today. Initially, I wasn't aware my healthcare experience was not the same for other persons combating the virus. When I became a peer advocate, and as I began to advocate for my community, I also began attending doctor appointments with clients. That's when I came to realize race, gender, and how one presents does make a difference in the healthcare received. I discuss with my clients, lost my place here. I discuss with my clients the need to establish a good relationship with all providers, that they were the MVP of their healthcare. No matter who was sent to save me or assist me, the outcome of my health rested primarily within my hands. I needed to drive that message home to many of my peers who were stuck in the throes of the virus without understanding what was happening because of it. It is so important for me to educate about the realities of living above this disease. Dark days come and go, but depression stays and haunts. Assisting my clients in finding a way in the dark, this was a priority. When you can't see outside your thoughts, can't think outside your thoughts, or beyond your circumstances, your health is often not the first thing on your mind. I had to make it clear HIV and AIDS does not sleep, and neither can you. Community health workers, peer navigators, providers with lived experience are all messengers of a way up. We are the ones with that special brand of sharing and direction giving to those who need it. We leave our biases at the door in the name of serving another. Our focus is finding that way in to make positive change and sound calls to action when necessary. Our outcomes on behalf of people, families, and communities as committed responders ignites and inspires what's necessary for people to be better and live stronger. Thank you, and back to you, Aurora.
Thank you so much, Alice, for those beautiful comments, as well as the wonderful blog that you have written and we will continue to be sharing out. We appreciate so much everything that you have done and you continue to do for your community. Next up, I would like to bring on Dr. Michelle Cespedes, who is the chair of the HIV Medical Association and a professor of medicine at the School of Medicine at Mount Sinai. And give me one moment to flip up these slides.
Thank you, everyone, for spending your afternoon with us. So first, I really want to just thank NACHW for really truly the invitation for inviting HIV-MA to participate in the webinar today. We are honored to be included in this first World AIDS Day webinar and really hope to partner with all of you in the coming future. So as Aurora mentioned, I am the current chair of the HIV Medical Association. associated with the Infectious Disease Society of America. And I really want to share with you some of the work and the advocacy that HIVMA is doing to address health inequalities and really to advocate for the workforce that exists, and also increasing the pipeline for future healthcare workers and allies that's needed to help end the epidemic, I should say. Next slide, please. So first, HIVMA's mission is to serve as a community for healthcare professionals to advance comprehensive and humane response to the HIV pandemic. And we really want this response to be informed by science and social justice. We are focused on increasing access to healthcare, services, and coverage for people living with HIV and at risk for HIV. So those who are uninfected, we want to keep them that way. And on sustaining and building a robust and diverse healthcare workforce. I want to share with you today some of the efforts that we've made so far and some of the work that we are continuing to do to help advance these priorities. Next slide, please. So as part of our work to improve health equity and make progress toward ending the HIV epidemic here in the US, we published a policy paper earlier this year that really outlines these 10 broad principles that are critical to expanding and improving healthcare access and delivery. I'm not going to read through all 10 of them, but I really wanted to highlight those that I think are really apropos for today. First, addressing the social determinants of health by ensuring economic stability, housing, and addressing structural racial inequalities. We understand that these are crucial and critical to improve the quality of lives and health outcomes for people with HIV. And essentially, all people, right? So it's not just HIV. Some of these principles can be expanded upon, but especially for people who are disproportionately affected by HIV. We also must consider thinking outside of the box, right? Thinking outside of traditional healthcare settings and meeting people where they are, literally and figuratively, right? If there's an issue, and especially here in New York City, we figured out ways to think outside the box when we needed to during COVID, right? For health delivery, we can do it, right? And I think we need to make sure that we remind people the new paradigms sometimes need new ways of thinking. The last principle of these 10 that I want to highlight is that we need a healthcare system to support and fund innovative care models that better meet the needs of people with HIV and those at risk for becoming infected. This includes funding mechanisms to ensure community health workers receive equitable pay. There's more information on our website, but as one of our board members mentioned a few weeks ago, it is really something to be said when a healthcare worker that works at this colleague's clinic actually does not qualifies for subsidized healthcare because of how little money they make. Next slide, please. And I'm not sure if you recognize the young lady in this photo on this slide, but we want to make sure that everyone has access and reads this excellent piece. But to help accelerate efforts to deliver healthcare to people where they are, HIVMA held a series of meetings over the summer, focused on the role of innovative delivery models in ending the epidemic. The models that we focused on were street medicine, right? And differentiated service delivery, or tailoring the intensity of services provided based on people's needs. Right? The goal of the meetings was to identify the policy changes needed to better support these innovative care models. Community health workers really play an important role in improving healthcare delivery. And we are lucky to have Alice as part of our team and actually being recognized for her work in this recent post. There'll be more details in another paper coming out in next month that's really going to summarize the policy and some of the recommendations. So we really hope to share those with you in just a few short weeks. Next slide, please. The key component of efforts to end the HIV epidemic, as I've mentioned, is expanding access to pre-exposure prophylaxis, PrEP, to really prevent those who are at high risk of acquiring HIV from becoming infected in the first place. PrEP, if you may not be familiar with it, is a highly effective tool to prevent HIV infection and involves either taking a pill every day, but there actually is a more recently approved option for a longer acting injections, right? So unfortunately, PrEP is not currently, I think we skipped a slide ahead, but PrEP is not currently reaching the populations most in need of the intervention. Only 14% of PrEP users who identify as Black, and only 17% of users who identify as Latinx are the current users of PrEP, despite being much higher, much more disproportionately affected or likely to acquire new HIV infections. Sometimes, as this data shows, that even though people of African descent only represent about 13% of the population or so, represent nearly 50% of all new infections on most recent data. So HIV-MA has long been working in coalition with HIV community partners and urging Congress to fund a national PrEP program to address these unacceptable disparities. Next slide, please. On the workforce front, we submitted a comprehensive list of recommendations to strengthen and diversify the HIV workforce for the National HIV/AIDS Strategy Implementation Plan. In developing these recommendations, there is a strong recognition among the HIV clinician community of the important role that community health workers play in HIV prevention and care. We noted in our recommendations that community health workers should be leveraged to support linkages to care and in other ways. We also urge that there be enhanced support for community health workers through higher salaries and also for professional development. We were pleased to see that community health workers were incorporated throughout the National HIV/AIDS Strategy Implementation Plan that was released. Next slide. Finally, I want to highlight a few of our resources developed for clinicians that may be helpful to both clinicians and to you in your work. The COVID-19 vaccination resource is regularly updated and includes the CDC's recommendations for staying up to date with COVID-19 vaccination. It also highlights special considerations for people living with HIV. HIV-MA strongly encourages all people with HIV to stay up to date with their COVID-19 vaccinations, but also all of their preventative care, right? We strongly encourage all people to stay updated with the booster as well that's now available. Because I still work in the hospital too, it's not just COVID-19, it's flu, it's RSV, but it's all the things that really disproportionately affect patients who are at risk and have HIV. And a lot of this are some of the syndemics throughout the country, right? Poverty, access to care, and oftentimes even socio-political issues. All right, so we also have a number of other resources available on Mpox, the new name for monkeypox, including a fact sheet that's been translated into Spanish, links to the HIV primary care guidance that's developed for clinicians, but can sometimes also be of reference or reviews. We have this and many other resources linked on our website, and the website address is listed there. And next and final slide, I wanted to thank you again for including HIV-MA in this seminar. Please do not hesitate to reach out to us as needed if you have any questions. And I really look forward to addressing any questions or comments that you may have at the end of the webinar for the open discussion. Thank you again.
Thank you, Dr. Cespedes. We really appreciate you being here today and sharing all these incredibly valuable resources. We'll also make sure they're shared out with everyone who's on the call today. So
Thank
thank you. Next up, I would like to invite on Dr. Tyler Evans, who is the CEO and founder of Wellness Equity Alliance. Please go ahead, Dr. Evans.
Well, thanks, and it's great to be here. And thanks to thanks to Michelle for presenting this great work that HAVMA is pushing out. I'm also sit on the board with Michelle, and I'm so proud of the work that we are pushing out and sort of advocating the importance of CHWs being a part of our sort of innovative clinical service delivery models that I think we really need to socialize more and have more traction on. I mean, I think if anything, the sort of collision of COVID and HIV is really important to highlight. And if anything, it's the sort of the silver lining of COVID to demonstrate the inequities in the systems that we work in, and how can we rebuild. And how can we address some of these inequities in a meaningful way? And I think CHWs are an absolute critical workforce that are going to help us rebuild and sew together some of these sort of tears, in the system. A little bit of a personal narrative or experience working with CHWs. I started getting inspired by getting in the sort of the fight against HIV in the late 90s in South Africa when I was still a student. And I saw firsthand the importance and the effectiveness of community health workers working out there in many areas where there weren't a lot of physicians or medical providers. And over time, as my training and my career further developed, I started really questioning why in the United States, where I was getting trained, why did CHWs did not have more of a sort of consistent or prevalent sort of presence in the HIV space, or really in the clinical space in general, and increasingly started realizing that that there were a number of access sort of issues with respect to reimbursement, et cetera. And so as sort of time progressed and I worked further in the public health space in the United States, I really thought deeply about how CHWs and clinicians can kind of work more closely, sort of hand in hand. And throughout the years, I've gone back and forth between the global South and the United States, both in my work with HIV, as well as working on other infectious disease outbreaks, including Ebola. And as I was working in places like Sierra Leone and South Sudan, again, community health workers kept coming up and became the critical workforce that got to connect the needed resources to the communities that were very much in need. So, getting back to the U.S. and particularly with the COVID-19 pandemic, it became clear to me as an individual that I needed to do more to advocate for for more placements of CHWs in the workforce. And so I was the chief medical officer for New York City during the first COVID-19 surge between March and October, and most of our work was focused on isolation and quarantine hotels. And as we were getting folks into these hotel rooms, we really struggled because they really just didn't trust us. There was a different presidential administration, or some say regime, and we were working for the city, right? We were working for government, and we didn't really have the faith and the trust of the communities to get folks in there. So we developed across the city, we developed a social determinants of health working group with over 60 different city agencies, and CHWs sort of kept on coming up. And as we kept working, it became very clear that we needed to engage more with CHWs. So sort of fast forwarding, a number of colleagues and I ended up identifying that, we need to do better. We need to really reimagine the public health network across the country. What's currently sort of operational right now is not working when it came to mass immunizations. We were obviously struggling with workforce in general. We didn't really have the clinicians in the public health spaces across the country, and we didn't have the folks that could actually kind of engage and connect to the different communities that we needed to connect with. When we first started standing up operations, we acknowledged that most of the folks that were getting into these we call it pods internally, or points of dispensing, but externally they were just vaccine clinics. Most of these folks kind of look the same, and we would ultimately sort of retrospectively describe them as the triple Cs, or Caucasians with cars and computers. And we knew that we needed to do better. We needed to really be intentional about where we were going to set up our access points, and we really needed to have the right people at those access points to welcome and engage communities who didn't trust the population and public health systems that we were working in. So we formed Wellness and Equity Alliance, where we ultimately administered over 2 million COVID-19 vaccines during the sort of the height of the pandemic, and this organization has now gone sort of way beyond that. And I'm going to share a few slides just about that, but really kind of focus on how community health workers are a critical workforce in this space. Next slide, please. So as we developed this organization, again, it was clear that we needed to really sort of be the future of public health, and we really needed to develop workforce that could connect between sort of the clinicians, between sort of community health, public health, and communities. And we really thought that the sort of private-public partnership was really sort of absolutely critical to address the inequities and the social determinants of health ultimately, because while we could create as many access points as possible, if we don't work with folks that really understand the needs and the barriers of certain communities, it's not going to work. Next slide, please. So this is our team. It's sort of the original team, or the OGs, as we would sort of call it, and this group sort of came together and formed what we're now known as Wellness and Equity Alliance. Next slide, please. And so we ultimately partnered with over 60 different government agencies across the U.S. And so again, that it's all about partnerships with public health agencies, partnerships with community health centers, and really the community health workers have been the sort of connective tissue between these agencies. Next slide, please. And again, it's just the public health infrastructure throughout the United States has been very fractured, and it's not because it's not good folks that are there. We're not set up for success in a number of ways, and so that's led to a number of inequities. And we felt that we were really successful because we could work quickly, whereas in sort of historical government agencies, it's very challenging to work in a sort of nimble way. And we could really also use data-driven approaches to address the social determinants of health. We work with a data science partner that has over 100 different data sets on the social determinants of health, which is really helpful to help us guide our operations. Next slide, please. So this just sort of describes some of the ways that Wellness and Equity Alliance can have impact. One sort of, we sort of describe ourselves working in 4 different sort of operational domains. One of them is standing up mobile primary care services, including a concept called street medicine that Michelle was presenting, where we can work with particularly people experiencing homelessness and provide the necessary primary care and prevention services to those individuals, whether it's in encampments or on the southern border of the United States. We need to get to folks in sort of challenging environments and really just meet them where they're at. the sort of the four walls and the sort of the white coats, that just doesn't work for a lot of folks. Communicable disease management, obviously starting with COVID and expanding further into HIV testing and prevention, absolutely critical. And these models, both primary care and communicable disease management, we work with community health workers and nurses side by side. As we started to expand this further, it became very clear that behavioral health services were absolutely essential. We've seen the inequities in the access for behavioral health clinical services throughout the United States for decades, but these inequities have been amplified as a result of the pandemic for a number of reasons. So, and that includes substance use disorder treatment. So, so this is now a part of our offerings. And then finally, providing public health authority in certain areas where it doesn't exist. We've started to become the public health officer or health authority on record in certain places like the city of Vernon and South Los Angeles. Next slide, please. So this just describes a little bit more about our need to address access, and this is something that HIVMA is very much sort of focused on right now. Access is something that I think inherently a lot of clinicians believe exists, but the reality is a lot of folks, while it may sort of theoretically exist, it doesn't exist in the minds of many communities because they just don't have the trust and the faith of the systems. So we need to do better and work again with CHWs to kind of get to sort of optimize that access. And I'm going to present a few different ways in which we can do that. Next slide, please. So first, you have to start with the analysis. You have to start with the community health needs assessment, and community health workers are absolutely essential in doing that. They can connect to different communities and really kind of ask the right questions. And identify ways that we can kind of help optimize that access. And looking at housing insecurity, that's sort of a sort of primary example of how we could do that. And it's not just about access for healthcare; it's also sort of access for housing and case management as well. Next slide, please. Behavioral health, as I was describing before, so important to include that in our primary care models as much as possible. We talk a lot about integrated behavioral health, super important to ensure that these two sort of components exist in the same space. We can really sort of optimize access. If we just talk about access just for primary care and we don't include behavioral health, especially it's for people experiencing homelessness. If we say, all right, here's your pill for HIV prevention, here's your pill for for substance use disorder treatment. But you got to make an appointment to get this other service at this sort of brick and mortar between the hours of 8 to 5, 3 weeks later. The likelihood of that taking place is very sort of low. So we really, again, have to meet people where they're at. So just really kind of max packing that access is just so important. Next slide, please. And so this just describes a little bit more about the importance of that sort of systems analysis and really looking at things from a 360-degree sort of lens. It's not just about the brick and mortar facility. You can't just look at that data. You really have to look around the brick and mortar and really understand, is there transportation that gets into that brick and mortar? Are there childcare options around there? All of these components really sort of help to create the ultimate sort of understanding of healthcare access. It's not just about the hours or the number of clinicians. We need to really kind of expand that and understand how certain social determinants ultimately determine sort of access. Next slide, please. We can skip that. Next slide, please. So just really wanted to end on this. The workforce development piece is absolutely essential for the work that we're doing with Wellness and Equity Alliance. We just presented at the COVID-19 Equity Summit at the White House a few weeks ago, and really just socialized the importance of building out community health workers, training programs across the country. Wellness and Equity Alliance wants to do this more, and we're going to be partnering with NACHW on a workforce development working group, and really identifying who are systems leaders that represent different sort of communities, and how can we set them up for success, and how can they recruit and train people across the country, and how can we get them paid in a meaningful way, and again get people into whether it's mobile units or into brick and mortars. How can we get them into care? Next slide. And this is just a few folks on our task force, as we call it, and just so proud to be working with them and being here with you guys at NACHW, and just thank you for sort of remembering the importance of World AIDS Day. And we got to think again. We got to think smarter, not harder. We got to really sort of do better. And I'm just so excited about the opportunity to work with NACHW and get more CHWs accredited, trained, and working side by side with clinicians across the country. Thank you.
Thank you, Dr. Evans. We look forward to that work as well. And for folks on the call, if you sign up for your newsletter, we'll be giving updates on that work and how you can get involved. Thank you, and we'll now are going to move on to our next and final speaker for today. Oops, pardon me, that's not the right slideshow. Give me 1 second. Here we are. Oops, sorry about this, folks. Oops, sorry, one moment, folks. While I pull this up, I will introduce our next speaker. We are excited to announce we have Dr. Harold Phillips joining us, who is Director of the White House Office of National Aid Policies, or ONAP. In his position, he leads the effort to set the administration's domestic HIV and AIDS priorities. This includes the monitoring and implementing the National HIV/AIDS Strategy, consulting with the Office of Management and Budget, coordinating with others on the Domestic Policy Council, the National Security Council, and the Office of the Global AIDS Coordinator, to ensure America's response to the HIV epidemic is accelerated, comprehensive, and reflective of the lived experience of those at risk and living with HIV. Thank you so much, Dr. Phillips, for being here with us today.
Thank you, Aurora, and thank you to the National Association of Community Health Workers and my colleagues at HIVMA. And Alice, great to see and hear from you again as well. I'm going to talk to you all a little bit about and try to put, I think, sort of a framework over some of the things that we've heard from the other presenters. And that framework is part of our national HIV/AIDS strategy and the effort to end the HIV epidemic in the United States by the year 2030. And I'm so pleased to be here with you all. And as we commemorate World AIDS Day and we think about the work that we still need to do to work toward ending the HIV epidemic, I'm going to talk to you about, next slide, the National HIV/AIDS Strategy, the federal implementation plan, which includes the actions the federal government is going to take to help end HIV, the role of our new quality of life indicators, which I'm so excited about, and which you all as community health workers play a huge part in sort of helping individuals live their highest, best quality life. I'm going to talk about the Ending the HIV Epidemic Initiative and then leave you with some food for thought as we move into action of trying to address the HIV epidemic. Next slide. And the next one. So now I'm going to talk to you about the strategy itself. So the strategy was released last year by President Biden at the White House. Part of what President Biden committed to, because he's long been an advocate for the HIV community and been solid on our issues from his time both in Congress, then his time as vice president. Also as vice president, he was part of President Obama's team when they released the nation's first HIV/AIDS strategy. And what President Biden committed to was two things. One, making sure that the United States had an updated national HIV/AIDS strategy should he be elected president, and restarting the White House Office of National AIDS Policy. So he did both of those things. In June of 2021, I was selected to be the director for the White House Office of National AIDS Policy. And one of my first tasks was making sure that we had an updated national strategy that incorporated everything that we knew about HIV and included actions that could lead us to ending the HIV epidemic. Next slide. So to do this, we developed a strategy that had a completely new vision for HIV and the United States. It centered around 4 measurable goals that included 21 objectives and 78 different strategies, incorporating what we know in terms of the evidence-based approach to ending HIV, the need for involving those with lived experience, the need for expanding our HIV workforce. So all of those objectives and strategies are within the plan itself. We focused on 8 priority populations based on the data, the national data that we have. And also, so it just doesn't become another one of those Washington-based documents. We also included indicators of progress. So ways to hold ourselves accountable as a nation for meeting the goals and achieving the goals that are in there as well. Next slide. Here on the screen are the 4 goals. Again, these are very measurable goals using our national data to be able to see where we are. The goals range from prevention to improving health outcomes, to reducing HIV-related disparities and health inequities, and then calls for greater coordination and coordination among all partners. The thing about this strategy that I think is also different is it's not just a federal strategy. It's a strategy that includes the ability of faith-based organizations, community-based organizations, academic institutions, the private sector and business community can all see where they can play a role in helping move some of those objectives and strategies forward. Like yesterday, I had a meeting of 20 business leaders at HHS as part of World AIDS Day, where businesses like CVS, Walgreens, Walmart, Match.com, and Uber all sort of talked about ways that they were going to align some of their efforts with the national strategy and begin investing in communities and helping us achieve some of the goals of the national strategy. So it's a national plan. It's not just a federal plan. Next slide. Here on the screen are the priority populations. And these are our priority populations that are prioritized based on our incidence, diagnosis, and viral suppression data. So these are the groups that have the greatest disparity when it comes to HIV. And if we're going to end the HIV epidemic, we need to focus on these populations because this is where we still have those huge disparities in access. When folks talk about HIV is over or decreases in the United States in numbers and cases of HIV, usually it is among gay white men. And when you look at the data, you can see clearly we still have a lot of work to do in communities of color. We have a lot of work to do when it comes to transgender women and people who inject drugs, given sort of the opioid and the crystal meth epidemic. Those rates are increasing as well and causing some alarms too. Next slide. Some of the highlights from the strategy are on the screen. Something that I want to point out that I've been pointing out as part of World AIDS Day, where World AIDS Day, we're focusing on equity as part of our theme. Racism is a serious public health threat. So if some of our systems and structures, they have not been built or created to serve everyone. It's just a fact. And then we need to rethink about sort of how do we recreate systems and structures that build connections and build bridges rather than walls and keep people out. Also, a new focus on people who are aging with HIV. In the United States, greater than 50% of the people with diagnosed HIV are over 50 years of age. It's a result of where we are with antiretroviral therapy, But as one ages with HIV, we have to begin to think about quality of life issues as well. And how do we help people still achieve and maintain maximum health throughout their lifespan? The other piece is this, and you've heard a lot from some of the other speakers about the syndemic approach, thinking about STIs, viral hepatitis, substance use, and mental health, and mental and behavioral health issues, all sort of intersecting. And how do we meet people where they are with the appropriate screening and then linkage to the appropriate services? You all play a key role in a lot of this. And an increased focus on syringe services programs and addressing those social determinants of health. Next slide. Next slide. So while the national strategy is a national strategy, we put out this, at the beginning of this fall, a federal implementation plan, that looks at what the federal government will do and how we will implement some of those strategies. So next slide. I'm thrilled that we had over 10 federal departments who committed to over 380 actions that span both program policy and research, and also coordination in different ways among those agencies to help move us forward on our overall goals. So we've got a national strategy, and now we've got a federal implementation plan, and we are deep into trying to implement. Next slide. It's quality of life indicators. Next one. I'm going to go a little bit faster. Quality of life is so multifaceted. I don't have to tell you all that. But when we called together a federal work group to think about a quality of life indicator, what they came back and told me is, listen, quality of life, we don't think we can have one indicator or one data set that would truly capture what we're hearing from the community. People with HIV are more than just their viral load numbers and their CD4s. There are other things that are getting in the way. Now that we've got treatment so easy, so simple, 1 pill a day or injectable, there are other things that are getting in the way and impacting the quality of life. So we need to be able to measure them. So what we have on the screen are a set of what I call a set or a suite of quality of life indicators for people living with HIV. And for the first time in the United States, we are saying this is important. It's more than just those lab values. It's about, how do you feel about your health, good or better health, unmet need for mental health services, food insecurity issues, employment issues, and being unstably housed or homeless. We previously had a homeless indicator, but you can be worried about your housing situation and it can impact your quality of life when it comes to housing long before you get homeless or on the streets or in a shelter. You could be living with relatives or friends and so now we have great data that also can measure unstably housed to homelessness. So we have more of a continuum. Next slide. Next slide, the EHE Initiative, just briefly, we are focusing on, we've got this slide, which I really like, talks about some of the disparities. And it also links to some of what you heard the other presenters talking about when it comes to HIV in the United States. Higher HIV incidence among gay and bisexual men and African Americans, including our women, larger gaps in PrEP coverage were also talked about, and lower viral suppression rates and higher HIV prevalence and more outbreaks that we're seeing. We have over 200 clusters of HIV within the United States as well. So this is the work that still has to be done to address these health disparities. Next slide. To help us do that, we've been focused on the 48 counties, including DC and San Juan, and the 7 rural states with substantial HIV diagnosis. They are dotted on the screen and also shaded in. This initiative is being led by the U.S. Department of Health and Human Services. And what it is this extra funding to these areas where we have the greatest disparities and greatest inequity when it comes to HIV. And they are using those funds in new and innovative ways. Some of those communities involve community health workers. If you ask me, all of them should, because you all are an important part of sort of that healthcare team. Next slide. This initiative aligns with our national strategy. It calls for us to accelerate our approach. It calls for a syndemic approach to it. And even though the initiative started in 2019, I've got on the screen some of the incredible results that we saw both in 2020 and 2021, which shows that our HIV community, they can get it done. When you give them the resources, they can get it done. Folks that were new clients in the Ryan White program, and now this is during COVID, this is the 2020 data, and an additional re-engaged 8,282. In health centers, they started folks on PrEP over 80,000 in 2021. So that's what the resources that we have been given. President Biden has requested for FY23 over 800 million for the initiative. We're still waiting to see what comes out of the FY23 budget from Congress, but we need Congress to really think about fully funding EHE, as some of our earlier speakers talked about. Next slide. I know I'm running out of time. Next slide, call to action. This is where it is. So again, like I said, this is a national strategy. It's not just what the federal government can do. I've also been clear about the federal government can't do it all. Like we saw during COVID, it was a lot of the private sector that stepped in and helped, and we thought new and differently and outside the box in order to get it done with COVID-19. We need to do the same thing when it comes to HIV. Next slide. When I think about you all and the role that you all play in achieving the national goals for the strategy, some important things pop out immediately to my mind. Assisting with scaling up some of the evidence-based HIV prevention and treatment interventions. Some of that involves you all as being an integral part of those care teams to be able to keep individuals connected, to assess risk, to assess some of the things that get in the way in terms of social determinants of health, and linking them to not only care and treatment, but those appropriate services. Also, that helps with retention and care, treatment adherence, encouraging holistic care for people living with HIV, health literacy. Like you heard folks talk about in the presentation today, there's still not a lot of knowledge about HIV. People also don't know that Black women are one of the highest prevalence groups in the United States, or that PrEP is available for Black women. Black women are not offered HIV tests, even when they show up for STI testing. So we got a whole lot of work to do in our community about health literacy, messaging about U equals U, untransmittable, undetectable equals untransmittable. Those who are on HIV therapy and maintain on therapy can't pass HIV on to their sexual partners. Being able to screen for risk. I was talking to someone yesterday about, many people don't feel like they're at risk. We're also trying to shift the dialogue. They've done some real great work that was funded talking to Black women about it. Black women tend not to think about risk because they got so much going on in their lives, both pillars within their families, their communities, their churches, all the rest of it. They don't think in terms of risk. So shifting the conversation to reasons for HIV treatment, reasons for HIV prevention, reasons to put your health first in order to help you do all those things that you do for our families and our communities, all the rest of it. So shifting that dialogue from risk to reasons why this is important. Also, helping us address HIV stigma, and finally, linking people to treatment. Those are the things that just came to my mind. You all probably have a whole lot more that you can think about that you all might be able to do as community health workers. And I'm so excited for this opportunity to talk to the National Association and hopefully get you all excited about World AIDS Day and how we move forward. I think next slide is my last slide. If I did this right, here are some additional resources that I wanted to leave you with that may help you all as you think about this work, think about engaging both at the national and the local level too. Resources from HRSA, HIV.gov. If you haven't signed up for their newsletter and their website, it's a great source for everything that's happening in the federal government with regard to HIV. Next slide. And CDC's campaign, Let's Stop AIDS Together. Putting ourselves to the test, achieving equity to end HIV was our theme for World AIDS Day, emphasizing that we have to lead with equity. And that not only, and I played on the word testing, we're testing ourselves as a nation. We've got all the tools to end this epidemic. It's really going to be up to us that we make sure There's both the knowledge, awareness, and access for communities most at risk. So thank you. And I think that should be it.
Thank you so much, Dr. Phillips, and all of our speakers today. It was a fantastic webinar overall, and people are blowing all of you up in the chat saying how useful they found all of this information. We did not receive any questions, and I know we are now out of time, but if folks do have questions, please feel free to drop them in the chat, and we can follow up with our speakers and try to get answers to your questions. We'll also have a evaluation survey pop up. You can also put your questions in there. I want to say once again, thank you to everyone who attended. We have had over 130 attendees today, which is a great outcome. Thank you to all our presenters. Everyone did a great job. Thank you so much for this information. We'll be sending out all your links that you shared today and your resources. So thank you, everyone. Please continue all the great work you're doing in your communities, and we hope to see you all again soon. Thank you.